Now we are entering into the ductal carcinoma. Grossly, it is like a serous carcinoma of the breast. Okay, very fibrotic, and microscopically you can see lot of sclerosis and see the main duct. It is connected with the ductal system. Microscopically, there are 7 types: ductal carcinoma NOS, colloid carcinoma, micropapillary carcinoma, signet ring cell carcinoma, medullary carcinoma, adenosquamous, hepatoid, and undifferentiated. Undifferentiated, we have 3 subtypes that are anaplastic, undifferentiated carcinoma with osteoclast like giant cells, undifferentiated carcinoma that can be sarcomatoid or can have both epithelial and stromal malignancy called carcinosarcoma. So these are the main types of ductal carcinoma of the pancreas. We will see individual pictures, and these numbers, I don't know why can they come up with one number. See here, for colloid carcinoma, you have to see more than 80% of the tumor made up of mucinous pool with floating cells. Adenosquamous carcinoma, you have to have more than 30% of squamous epithelium. Anaplastic carcinoma, you have to have more than 80% of tumor cells showing anaplasia. Micropapillary, you have to have more than 50% of tumor showing micropapillary pattern. For practical purpose, I use 50%. Okay, easy to remember. But I will always check with the books whenever I am seeing squamous component. How much is the component needed for the diagnosis? So this is a classic ductal carcinoma NOS. I told you grossly it is serous, and you can see lot of desmoplastic stroma in the background. And these glands are irregular. Normal glands are usually round. For example, here, these are normal glands. Whereas malignant glands, they are angulated or incomplete. This is good for any adenocarcinoma. For example, breast or colon or stomach. Those malignant glands are angulated or irregular or incomplete. And in the pancreas, you see in addition perineural invasions. And these tumors may be seen adjacent to big blood vessels. Infiltrative, incomplete lumina, nuclear variation more than 4 times next to muscular vessels, perineural vascular invasion and necrosis. These are very characteristic of ductal carcinoma of pancreas and NOS type. See the nuclear pleomorphism. Look at the smallest cell, look at the largest cell, more than 4 times. That means pleomorphism. And see the comedonecrosis here, and look at the mitosis. Here, nice perineural invasion. Here, we don't know, is it vascular invasion? Is it IPMN? To me, it looks more like a vascular invasion because or tumor cells lining the vascular-like channels. And immunohistochemically, whenever doubt, you can do P53 and SMAD. P53 will be mutant in pancreatic adenocarcinomas, and there will be loss of DPC4 or SMAD4 in pancreatic carcinoma. The background stromal cells act like internal built-in control, whereas the pancreatic carcinoma cells will be showing loss of SMAD4. Now we are going to see the subtypes of or types of ductal carcinomas. This you can see lot of mucin. So this is a mucinous carcinoma. Pools of mucin with it's the same thing like in mucinous carcinoma of the breast, but in pancreas, you have to see more than 80%. These are signet cells. So this is a signet cell carcinoma. Again, more than 80% of tumor cells should have signet cell features to call it a signet cell carcinoma. That's why in biopsy, you should never call mucinous carcinoma or signet cell carcinoma. You have to say this is carcinoma predominantly showing mucinous features or signet cells, because in biopsy, core biopsies, we don't know what is the rest of the tumor. So we can do the final subtype after getting the final specimen. In case of signet cell carcinoma, you have to rule out primary from the breast or signet cell carcinoma of the stomach. Here you can see nice squamoid components and a glandular component. So this is a adenosquamous carcinoma. Adenosquamous carcinoma, and the squamous component will be positive for P63. This, if you see here, this looks like a hepatocellular carcinoma, isn't it? But when you go to the low power, it's a well circumscribed tumor with adjacent pancreatic tissue. So this is a pancreatic carcinoma with a hepatoid features. This is a medullary carcinoma, well circumscribed tumor, lot of lymphoplasmacytic infiltrate. Tumor cells are arranged in a syncytium. This is the criteria for medullary carcinoma for all the organs. Pushing margin, syncytial growth, poor differentiation, and a lot of lymphoid cells. And the minute you see a lot of lymphoid cells, you have to think of PD-1 and PDL-1 because the immune modulators treatment will be very helpful whenever a tumor is showing a lot of lymphoid infiltrate, whatever may be the organ. That you have to keep it in mind. And these are undifferentiated carcinomas. So this is having both epithelial component and the epithelial component looks very anaplastic. So this is a undifferentiated carcinoma. Here you can see undifferentiated tumor with a lot of necrosis, and you can see osteoclast type of giant cells. So this is a undifferentiated carcinoma with osteoclast. This is undifferentiated carcinoma with micropapillary pattern. These are all papillae without fibrovascular core. And another characteristic feature, they produce artifact, tissue retraction artifact. So they look like a vascular invasion, but these are not blood vessels. So when you do IHC for endothelial cells, no endothelial cell will be there. These are retraction artifact. And why you have to know, these tumors have a very high incidence of lymph node metastasis. The other rare types of carcinomas are oncocytic carcinoma, non-mucinous glycogen poor cystadenocarcinoma, choriocarcinoma, clear cell carcinoma, and ciliated cell adenocarcinoma. This is the clear cells, and whenever you see clear cell, you have to differentiate metastatic renal cell carcinoma. But clear cells can be seen in more than one type of pancreatic tumors, solid papillary, pseudopapillary tumor, serous cystadenoma, neuroendocrine tumor, ductal carcinomas, picomas can have clear cells. So you have to be careful, look at the adjacent areas, what they are showing. If it is totally clear cells, as I told you, rule out mets from RCC and do immunohistochemistry to subtype the clear cells. And this is adenocarcinoma made up of ciliated. So these are ciliated columnar type of adenocarcinoma. This is a new entity. It's been described in the pancreas, I think in the lung also, and other organs also. So ciliated columnar cell adenocarcinoma. Acinar cell carcinoma, this you can see a very nice picture of fleshy growth and with lobulations and septae. It's in the tail of the pancreas, so it is invading into the spleen. Microscopically, it shows a very well circumscribed tumor made up of pink cells with indistinct cell border and round to oval nuclei with the prominent nucleoli, and you can see the prominent nucleoli in them. You may confuse it with oncocytoma, but oncocytes won't show this prominent nucleoli, and chymotrypsin will be positive in acinar cell tumor. Again, it can be classically solid, cystic, and it can be mixed with a neuroendocrine tumor and ductal carcinoma. In well-differentiated tumors, we can see the nice acinar formation with more uniform cells. That you have to keep it in mind. In addition to trypsin, chymotrypsin, this will also be BCL10 positive. And since madam asked, I checked the literature, they are telling glypican also is positive in acinar cell carcinoma. Pancreaticoblastoma, it happens in young age group. It's like a Wilms tumor, so it will have epithelial and stromal component. The epithelial component can be primitive, can be ductal, can be acinar, can be neuroendocrine, and squamoid eddies are very, very characteristically seen in pancreaticoblastoma. The stroma can be homogeneous or heterogeneous. Here you can see primitive cells from the pancreatic tumor, and you can see the nice squamous nest here, and you can see the squamous nest and more primitive cells in the background trying to form acinar pattern. And these cells are classically beta-catenin positive and can be also trypsin positive. Remember, I told you these are multi-lineage tumors. It can be ductal, it can be acinar, it can be neuroendocrine, it can be embryonal. So trypsin will be positive, and beta catenin, normally they are seen in the membrane. Whereas when you want to call beta catenin positive, it has to be seen in the cytoplasm and nucleus. I will show you a normal picture when we talk about solid pseudopapillary tumor, which is the next. The other name is Gruber-Franz tumor, because in the quiz they may ask you what is Gruber-Franz tumor. So it is nothing but a solid pseudopapillary tumor, and you can see solid areas and papillary areas. These are not real papillae. All the cells in between these papillae are disc cohesive and they shed. That's why it looks like papillary. Really, it is not papillary. That's why it is called pseudopapillary. And high power, it is characteristic having a coffee bean nuclei. See the nice coffee bean nuclei. And another interesting features is the hyaline globules. They produce intracellular and extracellular hyaline globules. This is what I am telling. This is the normal pancreas adjacent to solid pseudopapillary tumor, and normal beta catenin will be membranous positive. So you cannot call it beta catenin positive. This is normal pattern. Whereas here it is both in the cytoplasm and in the nucleus. So this is beta catenin abnormal expression. This is normal expression. This is abnormal expression. In addition to pancreaticoblastoma, the solid pseudopapillary tumor also shows beta catenin positivity, and it has characteristic progesterone receptor positivity and the CD10 positivity. Now we are entering into the exciting area of neuroendocrine neoplasms. Whatever I am talking about neuroendocrine neoplasm in pancreas more or less suits all the other organs. It's mainly divided into well-differentiated and poorly differentiated. Well-differentiated neuroendocrine neoplasm is called as neuroendocrine tumors, and they are graded into 3 grades, grade 1, 2, 3. Whereas poorly differentiated neuroendocrine neoplasm is known as neuroendocrine carcinoma, and there is no need to grade them because they are always grade 3. In addition to this neuroendocrine per se, they can be seen with mixed non-neuroendocrine neoplasm. So it is called MINN, mixed neuroendocrine, non-neuroendocrine neoplasms. Okay, and these numbers we will see it in the next slide. This is the pyramid you have to remember. The mitotic rate and Ki67 index is very, very important in neuroendocrine tumors. When you want to call neuroendocrine tumor, the mitosis should be less than 2 and the Ki67 index is less than 3. To call it grade 2, the mitosis should be 2 to 20 and the Ki67 3 to 20, and G3 more than 20 mitosis and more than 20% Ki67 positive. And I always tell my postgraduates, remember the middle one. Grade 2 up to 2 to 20 mitosis and 3 to 20 percent Ki67. If it is less than that, it is grade 1. If it is more than that, it is grade 3. Always remember the middle. And when you talk about grade 3, you may be thinking how to differentiate it from pancreatic neuroendocrine carcinoma, because that is also grade 3, even though there is no need to grade. We have to do P53 and retinoblastoma IHC. They are negative in pancreatic neuroendocrine tumor, but they are abnormal in pancreatic neuroendocrine carcinoma. In addition to that, DAX and ATRAX are positive in neuroendocrine tumor in addition to MEN1 protein, whereas KRAS and SMAD4 also positive in neuroendocrine carcinoma in addition to TP53 and retinoblastoma gene. This understanding is very, very important. So, and it captures in a nutshell the whole classification of neuroendocrine tumor. Well differentiated, poorly differentiated. Well differentiated is known as neuroendocrine tumor. It is graded into 1, 2, 3. Poorly differentiated is known as neuroendocrine carcinoma. This distinction of grade 3 neuroendocrine tumor and pancreatic neuroendocrine carcinoma is very, very important because the pancreatic neuroendocrine carcinoma has a very bad prognosis. So when you are starting the mitotic count, you have to go to the most active area and you have to calculate 50 high power field, but now they are telling in millimeter square. And when you count for 50 high power field, then you make them divided by 5 and make it into 10 high power field. Ki67, you have to count in 500 cells. What they do is they manually print out the tumor, and then what are all the Ki67 positive, they will just calculate and calculate the negative cells in the background, and thus they come up with the percentage. It is very cumbersome to do it manually, and artificial intelligence is going to help you wherever you are counting. For example, HER2 scoring, ERPR scoring, Ki67 scoring. In couple of years, artificial intelligence will be of great help. It's already the Western countries, they already started doing it. Probably in 5-6 years time in India, we will be doing artificial intelligence in all the quantitative pathology. Just want to show you the picture of people who are all behind these hard work about neuroendocrine tumors. David Straw from Memorial Sloan Kettering is leading with all the other doctors. I don't want to pronounce their name. Probably I may kill by pronouncing them wrongly. The main difference between well-differentiated neuroendocrine tumor and neuroendocrine carcinoma, hormone expression, hormonal syndromes, and hereditary syndromes are seen in neuroendocrine tumor. They are not seen in neuroendocrine carcinoma. This is one of the nice grass picture. Because of that, I took this slide, and it shows pancreatic neuroendocrine tumor here and a nice intravenous emboli, and this is Atrax mutant. And see how nicely the histological sections are showing that neuroendocrine tumor emboli in the vein. The interesting terminology, Minan, you have to have a very crystal clear idea. Before going into Minan, when you see two tumors separately, they are known as collision tumor. When you see two tumors mixed with each other, they are known as mixed tumors. And mixed tumors, either component can be prominent. Here, neuroendocrine component, the red one is the neuroendocrine component. It can be neuroendocrine component predominant in this end, whereas non-neuroendocrine component predominant in this end. But when you see a cell that has both endocrine and non-neuroendocrine features, like a goblet cell carcinoma, it is known as amphicrine tumor. So you must know the definition of collision tumor, mixed tumor, and amphicrine tumor. When you come to mixed tumor, remember this person, 30. To call it mixed tumor, each component should be more than 30%, but less than 70%. Okay, so it should be more than 30%. The understanding of the terminologies are very, 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 very important, and it is the same for all the organs. So this is a neuroendocrine tumor, nice neuroendocrine tumor in the body of the pancreas, and it may show some cystic changes also. Here there are multiple tumors. It is associated with MEN1 syndrome. And this is the morphological picture. It can be seen as nests or it can be seen as ribbons. And the microscopically high power picture is very, very important. See, the cells are more or less uniform and they have the characteristic salt and pepper chromatin pattern. And some of the cells may look plasmacytoid. So the salt and pepper chromatin pattern and plasmacytoid cells are classic of neuroendocrine tumors. And it may produce serotonin and that create a lot of sclerosis, or it can produce some proteins that are arranged in beta pleated appearance and gives rise to amyloidosis. For example, insulinoma can create a lot of insulin that gets malformed and form amyloid. So this is a grade 1 neuroendocrine tumor. Remember, we divide them into functional and non-functional. Functional, it can be glucagon, it can be insulin, it can be somatostatin. Morphologically, we cannot differentiate except somatostatinoma. In somatostatinoma, you see a lot of somoma-like calcifications. So in any neuroendocrine tumor in the pancreas, if you see a lot of somoma bodies, it is a diagnostic of somatostatinoma. Neuroendocrine carcinoma, grade 3, it can be divided into small cell and large cell. Small cell is similar to small cell carcinoma of the lung. Crush artifact, a lot of apoptosis and mitosis, but because of the hyperchromatic nuclei, you may not be able to see the mitosis. And this is a large cell neuroendocrine tumor with a minor component of small cells. As I told you, the markers are very important to differentiate neuroendocrine tumor grade 3 and neuroendocrine carcinoma. P53 is abnormal in neuroendocrine carcinoma. The lower one is neuroendocrine carcinoma. So it is abnormal in neuroendocrine carcinoma. Retinoblastoma gene is abnormal. It is lost in neuroendocrine carcinoma. And SSTR2A is positive in neuroendocrine tumor. So let us see the pictures. This is neuroendocrine tumor grade 3. This is neuroendocrine carcinoma. Ka67, even though both are having more than 20%, the neuroendocrine carcinoma will have 70 to 80 to 100%. Okay, very highly mitotically active. TP53 is abnormal in neuroendocrine carcinoma. And this picture shows neuroendocrine tumor grade 3 that is positive for SSTR2A, 3 plus positivity. Whereas the SSTR2A positivity become less in neuroendocrine carcinoma. That you have to remember. So how to use Minan? The summary slide. Identify the two components by morphology. Confirm it by immunohistochemistry. Classify the two components by morphology and immunohistochemistry. For example, Ki67 to grade the neuroendocrine tumor. Then quantify the components. You have to have more than 30% of the components to call it mixed neuroendocrine, non-neuroendocrine carcinoma. This is the best example. You can all identify the serous cystadenoma, and here it is neuroendocrine tumor grade 2, which is positive for neuroendocrine marker synaptophyse. This is a duct formation and neuroendocrine. So it is adenocarcinoma, neuroendocrine carcinoma, grade 2. This is a classic nice picture. This is more like acinar cell carcinoma, whereas here it is neuroendocrine carcinoma. So synaptophysin should be positive here and trypsin should be positive here. And this is trypsin positive in acinar component, and this is synaptophysin positive in the neuroendocrine.